The following podcast is part of a certified educational activity titled Beyond the Basics of Immuno-Oncology, Navigating Clinical Challenges to Maximize the Benefits and Minimize the Risks of Cancer Immunotherapies. Access the entire activity and complete the post-test at peerview.com/JHZ860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Evan Lipson. I'm an associate professor of oncology and a clinical researcher at the Johns Hopkins Kimmel Cancer Center in Baltimore. My work focuses primarily on developing immunotherapies for patients with advanced skin cancer.
I'm Trish Brothers, a senior clinical research nurse at Johns Hopkins. My work in clinical immuno-oncology research includes patients with a variety of tumor types. Welcome to this educational activity focused on the management of patients receiving immune checkpoint blocking therapies.
The main focus of our discussion today will be on the recognition, workup, and management of immune-mediated adverse reactions, both in routine clinical practice and in the clinical trial setting. The list of FDA-approved immune checkpoint blocking drugs continues to grow. Ipilimumab is the only FDA-approved CTLA-4 blocker. There are 3 PD-1 agents available: cemiplimab, nivolumab, and pembrolizumab. The FDA has approved 3 PD-L1 agents: atezolizumab, avelumab, and durvalumab. Of note, there is 1 FDA-approved combination therapy, ipilimumab and nivolumab. And in addition, some immune checkpoint inhibitors are now approved as components of multi-drug regimens that include cytotoxic drugs or other agents. There are many agents targeting various experimental immunoregulatory molecules being administered in the clinical trial setting. For example, you'll see on the screen now T-cell targets for immunoregulatory antibody therapy contain molecules such as LAG-3 on the bottom right. There are clinical trials going on at the moment testing anti-PD-1 plus or minus a LAG-3 antibody. As immune checkpoint blockers are tested and approved for an ever-growing list of indications, toxicity management issues are arising with increasing frequency.
There are numerous cancer types that are now treated with immune checkpoint inhibitors as standard of care. The first FDA approval came in 2011 for patients with melanoma. Since then, the FDA has approved several additional checkpoint blockers for patients with a variety of cancers, including lung, kidney, and breast cancers. Immune checkpoint blocking agents were first used in patients with treatment-refractory metastatic disease. Subsequently, these drugs were approved for patients in the first-line and adjuvant settings. Currently, in clinical trials, our immune checkpoint blockers are being used in the neoadjuvant setting.
Immune checkpoint inhibitors have revolutionized the successful treatment of patients with various types of cancer, but are associated with a spectrum of unique inflammatory toxicities called immune-related adverse events, abbreviated IRAEs, or immune-mediated adverse reactions, abbreviated IMARs. In general, those terms are used interchangeably.
One critical step in keeping patients safe is educating them and their caregivers about what to watch out for and the importance of keeping in touch with their treatment team. Dr. Lipson and I take every opportunity to educate our patients about the importance of communication during and after treatment. We also discuss that early detection and treatment of side effects can improve outcomes. For patients, it helps to provide a diagram explaining the mechanism underlying many of the toxicities that we see. So this is a diagram showing the IMARs that are associated with the immune checkpoint inhibitors. Our T cells that usually leave normal parts of our body alone now have a go signal to cause inflammation to any part of the body, and no part of the body is left unchecked. If a patient has received an immune checkpoint therapy, they have the potential to have a side effect, an immune-mediated adverse reaction or an inflammation to any part of the body.
Because IMARs can be so wide-ranging in their presentation, it can be challenging to provide patients with a comprehensive list of possible symptoms. We generally discuss some of the most common and potentially serious toxicities. The more common immune-mediated adverse reactions include some dermatologic issues like a rash or pruritus. Oftentimes, when things get more serious, blisters might form. Additionally, we might see gastrointestinal toxicities such as diarrhea, colitis, transaminitis, or hepatitis. Endocrine immune-mediated adverse reactions occur not uncommonly, thyroiditis, for example. And then every now and again, we'll see a serious toxicity such as pneumonitis or inflammation of the cardiac system. We do tell patients that these can be quite wide-ranging, and any change in symptoms requires a phone call to us within 12 to 24 hours. Patients often ask what % of patients experience a serious or grade 3 to 4 immune-mediated toxicity with the various regimens. And although it differs a little bit depending on which study you read, in general we think about it as combination therapy bringing about serious adverse reactions in about 60% of patients. Anti-PD-1 or anti-PD-L1 monotherapy usually results in grade 3 to 4 toxicities in perhaps 15 to 20% of patients. And then ipilimumab used alone results in a grade 3 to 4 toxicity rate of about 28%.
Several estimates regarding the timing of appearance of IMARs have been published. However, it's important to remember that toxicities can occur at any time during therapy and for many months after treatment has been discontinued. On the screen is a graph illustrating the typical timing of onset of some common IMARs. However, in practice, we see that adverse events sometimes occur within a day or two of initiation of therapy and might present up to a year after discontinuation of treatment. The biological effects of immune checkpoint therapies persist long after the drug has been cleared from the body. We also make sure that patients know the names of the therapies they are receiving. Because the drug names can be unfamiliar, we provide wallet cards that contain those names and our contact information. If patients require care, for example, in an emergency department setting, we ask patients to provide the wallet cards to the emergency care team and request that they reach out to a member of the medical oncology team. This is an example of the Oncology Nursing Society wallet card. At our institution, we give these out to every patient that may be receiving an immune checkpoint. We can list the name of what drug they're getting, the first dose of the drug, the date, as well as their oncologist, the triage number to call, and emergency to keep patients safe. And especially if patients are getting treatment for an emergency outside of the cancer center, it's good to have this wallet card on them so that the ER physicians and nurse teams at other hospitals will be able to quickly see that they're on an immunotherapy drug. Our approach to managing IMARs includes education of the entire team, including office staff, triage team members, etc., that any organ system can be impacted and that early recognition, evaluation, and treatment are critical for patient safety. Clinical findings, laboratory abnormalities, and patient symptoms that occur after initiation of therapy should be evaluated promptly, and an immune-mediated adverse reaction should remain on the differential until proven otherwise. IMARs are often diagnosed by exclusion after evaluating for other causes, such as infections, reactions to other medications, metabolic derangements, and tumor progression.
In the clinical trial setting, it's important to grade toxicities according to the criteria specified in the protocol document, such as the NCI's Common Terminology Criteria for Adverse Events, or CTCAE. Similarly, in routine clinical practice, we often categorize toxicities as mild, moderate, or severe. The general management of IRAEs in patients undergoing checkpoint inhibitor therapy generally falls into 3 categories: graded 1, 2, and 3-4, or mild, moderate, and severe. For a grade 1 toxicity in general, checkpoint inhibitor therapy might be continued with close monitoring, with the exception of some neurologic, hematologic, and cardiac toxicities. For a grade 2 toxicity with mild to moderate symptoms, oftentimes the checkpoint inhibitor therapy is held. We do consider resuming immunotherapy when symptoms or lab values revert to grade 1 in a reasonable period of time. In general, for grade 2 toxicities, corticosteroids are needed, usually at a low dose, 0.5 to 1 milligram per kilogram per day of prednisone or equivalent. We'd like to see that a grade 2 toxicity begins to resolve and go toward grade 1 within 48 to 72 hours. If not, oftentimes those grade 2 symptoms escalate and become grade 3-4, or severe or life-threatening. For grade 3-4 or severe or life-threatening toxicities, we almost always hold immune checkpoint inhibitor therapies. These toxicities require initiation of high-dose corticosteroids, which means prednisone 1 to 2 milligrams per kilogram per day, or methylprednisolone intravenously 1 to 2 milligrams per kilogram per day. The intravenous administration of methylprednisolone is particularly important in patients who are experiencing diarrhea. Oftentimes, orally administered prednisone in that setting is not absorbed sufficiently. If symptoms of a grade 3 or 4 toxicity do not improve within 48 to 72 hours of high-dose corticosteroids, infliximab, the tumor necrosis factor inhibitor, might be offered for some toxicities. In general, we taper corticosteroids over the course of at least 4 to 6 weeks. A faster taper will often bring the toxicity right back. And in select cases, when symptoms or laboratory values revert to grade 1, sometimes we can re-challenge with immunotherapy very cautiously. Dose adjustments in the checkpoint antibody space are generally not recommended. For grade 4 toxicities, in general, permanent discontinuation of checkpoint inhibitor therapy is warranted. Some additional items we consider for patients who are receiving long-term steroid treatment, for example, over 20 milligrams of prednisone per day or equivalent for more than about 4 weeks, include prophylaxis against opportunistic infections such as pneumocystis, pneumonia, and GI prophylaxis with a proton pump inhibitor or an H2 blocker. Sometimes we also consider administering vitamin D and calcium supplementation to decrease the risk of osteoporosis in patients expected to receive a prolonged course of steroids. Just a note about a steroid refractory toxicity. So what does it mean when we say that a toxicity is steroid refractory? Well, one possibility is that immune-mediated symptoms do not begin to resolve within 48 to 72 hours after initiation of appropriately dosed and administered corticosteroids. For example, intravenous methylprednisolone given for grade 3 diarrhea. In those cases, we might consider infliximab. In other cases where we think we might be dealing with an antibody-driven process, like some rheumatologic and neurological toxicities, we often consider using intravenous immunoglobulin, IVIG, or plasmapheresis. The second setting where we might think of a steroid refractory toxicity is when an immune-mediated symptom initially resolves after initiation of appropriately dosed corticosteroids, but returns despite a prolonged steroid taper. In those patients, too, it's often appropriate to consider using infliximab. Extensive research is now underway to better understand what therapies are available to patients whose toxicities are refractory to glucocorticoids and TNF inhibitors. We often recommend that clinicians consult a multidisciplinary team who have experience with immune checkpoint inhibitors when patients present with symptoms that need therapy beyond glucocorticoids and infliximab. Oftentimes, patients will ask whether the immune-mediated adverse reactions are associated with an anti-tumor response, and in some studies that does seem to be the case. There is an association in this study you'll see with overall survival and the occurrence of an immune-related adverse event.
Patients often ask whether medications required to treat immune-mediated toxicities impact the anti-tumor response. Studies suggest that immune suppression, such as steroids or infliximab administered to treat immune-mediated adverse reactions, combats the toxicity but does not reverse the anti-tumor effects of immune checkpoint blockers. Let's now focus more in-depth on some common and less common immune-related toxicities that patients face related to immune checkpoint cancer therapy.
One toxicity we see commonly involves dermatitis or pruritus.
This can present alone or in combination. It can be very debilitating to the patient, and it can become a quality of life issue.
Possible presenting symptoms might include an erythematous, maculopapular, crusty, sometimes scaly, perhaps blistering rash. Itching can be sporadic, it can be localized or generalized. Every now and again, a Stevens-Johnson or TEN type reaction will occur, although these are rarely fatal, that does occur.
We also have to look at, is the patient experiencing a different drug reaction? Are they having an allergy to something, contact dermatitis, liver toxicity? It's also important to note that if blisters are part of the rash in any form, it increases the rash by 1 grade.
Workup for these sorts of toxicities includes a comprehensive history and physical examination, including assessments of other potential etiologies like infection, exposures, other drugs, other disorders. One has to consider that sometimes a rash is a manifestation of a systemic toxicity like dermatomyositis. We often consider clinical monitoring with the use of serial clinical photography. In complex cases, we often consult our dermatology colleagues, perform a skin biopsy, and occasionally serologic studies are considered if an autoimmune condition, such as dermatomyositis, is suspected.
How do we treat these? The topical intervention, if less than 30% of the body's surface area. If it's more than that, they can apply lotions, but it's really not going to get on top of the rash or the pruritus. You want to do systemic therapy in that case. Oral prednisone sometimes works. Something to be considerate of is that itching may be a long-lasting side effect. We've seen patients that have stopped drug years past and still have itching the minute we try and stop them off their low-dose prednisone of 5 to 10 milligrams per day. Sometimes we'll give them a prescription for selective H1 or H2 blockers, hydroxyzine, again, low-dose prednisone for mild symptoms, 10 to 20 milligrams a day, and they may be on this for a long, long time. And sometimes you'll have to do a higher dose prednisone if the itching is very pronounced or the rash is covering more than 30% of their body. Diarrhea and colitis. This is a common toxicity we see with all of the immune checkpoint blockers.
Unfortunately, this is quite common, and unfortunately, it can become quite serious quite quickly. Possible presenting symptoms include abdominal pain, cramping, blood in the stool, watery stools, loose stools, stool urgency. Occasionally, this is accompanied by fever. It's important to note that assessments of these signs and symptoms need to be compared with the patient's baseline. Some patients at baseline have 2 or 3 stools a day, and so an increase there is different than somebody who has a stool every other day.
And for the differential diagnosis, we're going to check them for C. diff if they have been exposed in the hospital setting, other medications, or if it's growth of their tumor or tumor-related.
Workup, of course, includes a comprehensive history and physical examination. As Trish mentioned, inquiry about sick contacts or other drugs that might cause diarrhea. I'm recalling a patient several years ago that we saw whose primary care physician increased his dose of metformin, which was the reason for his diarrhea. It was not the immune checkpoint drug. Food exposures can also be important if there's been a change in diet recently with higher fiber foods or greasy foods. We need to assess the frequency and other symptoms oftentimes to determine the grade of the colitis or diarrhea, the presence or absence of blood, the presence or absence of severe abdominal cramping, for example. And as Trish mentioned, it's important to test for C. diff for any patient who's been in a healthcare setting.
For treatment, we can give antidiarrheals for patients that have a grade 1 toxicity, and sometimes those do help. We may need to give them intravenous corticosteroids depending on the grade, especially if it's a higher grade and whatever they're taking in is just going out. If they try and take something orally, it's not going to be absorbed. And we may want to consider a GI consult for scope, biopsy, and rapid pathological review if the diarrhea and colitis does not resolve or improve within 72 hours of the first corticosteroid administration.
Of note that infliximab is particularly effective in patients who have steroid refractory diarrhea and colitis. The dose is 5 milligrams given intravenously times 1. It might have to be repeated every few weeks or so. One common toxicity we see is thyroiditis. Oftentimes we pick this up as a routine lab abnormality and patients present asymptomatic. Possible presenting symptoms might include diarrhea, tachycardia, sore throat, a tender or painful neck on examination, nervousness, insomnia, or tremors.
Differential diagnosis. It could be a viral syndrome, inverted central line, or other causation. For working these patients up, we would check their thyroid function test, a TSH, a free T4, a free T3, and we would consider infectious causes. Could it be the flu or something else going on?
It's important to realize that thyroiditis often presents first as hyperthyroidism, followed by hypothyroidism. And that transition can be quite rapid. It's important that we check thyroid function tests every couple of weeks during that period to prevent the patient's thyroid function from dropping too low. If the patient is symptomatic during the hyperthyroid period, in general, we don't use the standard drugs that are used in typical clinical practice for hyperthyroidism, like methimazole. But we do treat these symptoms. For example, tachycardia or diarrhea might get treated with a beta blocker or an antidiarrheal. However, once the patient develops hypothyroidism, and a good percentage of them will, it could take months to adjust the level of levothyroxine replacement. Pneumonitis is a potentially serious and life-threatening toxicity. Fortunately, it's not super common, but when it does happen, it's important that it's picked up in a timely fashion.
A patient could present with new onset cough, change in their baseline cough, dyspnea, wheezing, chest pain, change in breathing or effort.
The differential diagnosis here, unfortunately, is quite broad and includes pneumonia, a COPD exacerbation, oftentimes seen in smokers or patients with lung cancer, an asthma flare, growth of the cancer, particularly with lung cancer that can present as lymphangitic spread. A pulmonary embolism can certainly cause shortness of breath and chest pain. And immune-mediated cardiovascular toxicity can mimic the signs and symptoms of a pneumonitis.
We would work the patient up by asking if they'd been around anyone sick. We would assess their respiratory rate and oxygen saturation level with and without exertion. Check for RSV or influenza. We would do a chest CT. And we would also tell the radiologist that we suspect that it may be immune-mediated pneumonitis when we are sending the patients for scans.
Treatment for these patients often involves empiric antibiotics and corticosteroids. Oftentimes we'll send the patient for a bronchoalveolar lavage and tell the pulmonary team that we suspect an immune-mediated pneumonitis. Occasionally, when we have nailed down the cause of the patient's pulmonary embarrassment, we'll be able to peel back either the antibiotics or the corticosteroids. However, in many cases, patients are left with a course of both therapies. Of note, it's important to use caution in patients with lung cancer. As I mentioned a moment ago, teasing out the etiology of pulmonary compromise in those patients can be quite challenging. Immune-mediated hepatitis is something we see not infrequently. Oftentimes, like thyroiditis, it's something you pick up as a lab abnormality, and patients often present asymptomatic.
The possible presenting symptoms may be elevated AST or ALT, an increase in their bilirubin. They may have nausea, may have vomiting, dark urine, jaundice, or abdominal pain.
The differential diagnosis includes the viral hepatitis, hepatitis A, B, or C. Certainly acetaminophen toxicity or alcohol toxicity could be etiologies, a thromboembolic event such as a Budd-Chiari, or metastatic disease.
For workup, we'll do a complete history and physical. We'll assess for toxin exposure such as alcohol or acetaminophen. We'll check for viral hepatitis, and we'll consider a liver ultrasound in some patients.
Treatment involves holding the immune checkpoint therapy, discontinuing other potentially hepatotoxic medications, and administering high-dose corticosteroids, at least 1 milligram per kilogram per day. I will say that many of our patients have required higher doses than that. If liver enzymes don't decrease within 48 hours of starting corticosteroids, we often do increase to the higher dose of methylprednisolone, 2 milligrams per kilogram per day, and sometimes we add mycophenolate mofetil. Of note, infliximab is generally not used in patients with immune-mediated hepatitis. That drug has been associated with its own hepatotoxicity. Another relatively uncommon toxicity involves immune-mediated pancreatitis.
Immune checkpoint blocking agents can cause asymptomatic elevations in serum amylase and lipase, and these patients often do not require steroids to treat asymptomatic elevations, but they could possibly present with epigastric pain, diarrhea, nausea, vomiting, or floating stools.
On the differential diagnosis, one has to consider that a stone might be blocking a duct. Alcohol abuse can certainly cause this. Gastritis can cause some of the symptoms that Trish described, and hepatitis can as well.
And we'll do a comprehensive history for workup. We'll check their serum amylase and lipase, as well as the CMP, and sometimes we'll do an abdominal ultrasound.
In general, when patients are asymptomatic, as Trish pointed out, it's okay to monitor patients, educate them to avoid alcohol and fatty foods. When patients are symptomatic, corticosteroids are effective in most cases. In general, we try to reassess amylase and lipase levels as well as a good clinical examination within about 72 hours. If symptoms and serum amylase and lipase don't turn around within a few days of having started corticosteroids, here again infliximab is generally particularly effective. Arthritis is quite common in the general population, and so when it presents as an immune-mediated toxicity, it can be difficult to tease it out from the patient's baseline.
So possible presenting symptoms include joint swelling, joint pain, joint stiffness, muscle pain or soreness, weakness, and often involves greater than one joint. It could be bilateral knees or hands or wrists.
Workup in these cases includes taking a good rheumatologic history and doing a good exam of the peripheral joints and spine, looking for tenderness, swelling, and limits of range of motion. We often consider imaging to evaluate for metastases or look for joint damage. In cases where we suspect that there is a rheumatologic event going on, we often check serum ANA, rheumatoid factor, anti-CCP, a SED rate, and a CRP. And quite frequently, we refer them early to our rheumatology colleagues for a comprehensive evaluation. Treatment for a grade 1 immune-mediated arthritis generally involves analgesics, oftentimes over-the-counter acetaminophen or NSAIDs. When toxicity gets to grade 2, we often hold the immune checkpoint agent and consider prednisone 10 to 20 milligrams per day, often tapered over 4 to 6 weeks. In some cases, we consider intra-articular steroid injections, especially for large joints. If toxicities rise to the level of grade 3 or 4, or if we're unable to decrease the steroid dose to less than 10 milligrams per day after about 12 weeks of therapy, oftentimes we'll consider higher dose oral prednisone, 0.5 to 1 milligram per kilogram per day, or a DMARD such as methotrexate or leflunomide. We certainly do this in collaboration with our rheumatology colleagues. Fortunately, immune-mediated adrenal insufficiency or hypophysitis is a rare toxicity. However, when it does occur, it's important that it's caught in a timely fashion, as it can be life-threatening.
The possible presenting symptoms could include headache, low energy, decreased appetite, dizziness, depression, lethargy, or hypertension.
On the differential diagnosis, depression, neurological toxicity, a reaction to another drug, or of course, central nervous system metastases.
And we're going to work these patients up. We're going to do a full lab panel, CBC, with DIF, CMP, serum cortisol level. We'll check their thyroid functions, and we'll do a dedicated brain MRI for pituitary cuts.
It's important to note that in cases where you might suspect adrenal insufficiency, a low serum cortisol is enough to make the diagnosis and to start corticosteroids. The treatment for hypophysitis or suspected adrenal insufficiency oftentimes includes high-dose corticosteroids in the acute phase, perhaps for the first week or two, and then hydrocortisone replacement therapy, usually 10 milligrams in the morning and 5 milligrams in the afternoon thereafter. In most cases, patients require lifelong hydrocortisone replacement therapy, and this is almost always done in consultation with an endocrinologist. Another uncommon but potentially serious toxicity involves the cardiovascular system.
The patient may present with dyspnea, orthopnea, lower extremity edema, chest tightness or pain, palpitations, cough, dizziness, or syncope.
In the differential diagnosis, of course, is myocarditis, pericarditis, pneumonitis, a side effect of another medication, infection, a myocardial infarction unrelated to immune checkpoint therapy, the spread of the patient's cancer, or a pulmonary embolism.
We'll take a complete history and physical of the patient with paying special attention to any new drugs, any sick contacts, too much caffeine, etc. We would get a rapid cardiology consult, check serum troponin, CKMB, BNP, ECG, echocardiogram, chest X-ray or chest CT, and a cardiac MRI if suspected of immune-mediated myocarditis.
Of note, if an immune-mediated cardiovascular toxicity is suspected, high-dose corticosteroids are indicated. Therapy should be administered in collaboration with a cardiologist, and in general, these patients need admission to a medical intensive care unit. Immune-mediated neurological toxicities are uncommon, but when they do present, they can be difficult to diagnose. The symptoms often mimic other conditions.
Possible presenting symptoms: the patient could have a headache, altered mental status, new or worsening weakness, numbness, imbalance, or gait abnormalities.
On the differential, we consider myasthenia gravis, Guillain-Barré, peripheral neuropathies, aseptic meningitis, encephalitis, or transverse myelitis, depending on the exact presentation.
We're going to do a history and physical exam and pay close attention to the timing and severity of the symptoms. We'll evaluate for status of tumor. Are they having a spread to the brain? Is something else going on? and we will consult our neuro colleague stat.
It should be noted that although administration of corticosteroids is often indicated when treating patients with neurological IMARs, many conditions are antibody-driven and sometimes require intravenous immunoglobulin therapy or plasmapheresis. And so therapy for these patients should always be administered in collaboration with a neurologist. When symptoms become severe, oftentimes patients require admission to a neuro-ICU.
Although rare, hematologic, renal, and ocular toxicities occur, and it's important to know how they present. Possible presenting symptoms with hematologic toxicities would include anemia, thrombocytopenia, unusual bleeding or bruising, fatigue, hematuria, melena, or maybe totally asymptomatic. We would consult hematology with these patients.
Ocular toxicities include inflammatory uveitis, conjunctivitis, iritis, or episcleritis. Oftentimes, patients present with double or blurry vision, eye pain, eye dryness, eye redness. We certainly consult ophthalmology in these cases. It's important to note that oftentimes patients who present with an immune-mediated Sika syndrome, where their eyes, mouth, and throat are dry, can have symptoms that mimic some of the ocular toxicities.
For the renal toxicities, the patient could have increased serum creatinine. In absence of any other cause, they could have low urine output, hematuria, peripheral edema, or maybe totally asymptomatic again, and we would consult nephrology with these patients. And there are many, many more toxicities that we could never name, as the human immune system is unique to the individual, and so are the toxicities.
Immune checkpoint therapy awareness training should be provided to everyone who has patient contact, patient care associates, triage nurses, office staff, advanced practice practitioners, everybody. In complex cases, I encourage you to consider consulting a large academic center, many of which are developing multidisciplinary groups comprised of subspecialist consultants who can assist in patient management.
A few key points before we wrap up. If patients are receiving or have received immune checkpoint blocking therapy as part of their treatment regimen, they are at risk for immune-mediated toxicities even after discontinuation of the drug.
Patient signs and symptoms that occur after initiation of therapy should be evaluated promptly, and an immune-mediated adverse reaction should remain on the differential until proven otherwise. Toxicity-specific patient management guidelines are available at the NCCN website.
This concludes our presentation. We hope you have found the material presented here informative and useful to your practice.
Thank you for taking the time to join us today. We encourage you to complete the post-test and evaluation form, and we look forward to reading your feedback.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JHZ860. This educational activity is supported through independent medical education grants from AstraZeneca and Bristol Myers Squibb.